Today we're going to talk about primary assessments. As you can see, generally the same thing. We approach it every way. Find it, fix it. Now this can be dependent on type of scene, situation, may have other factors too, but straightforward primary assessment relies on three things. Purpose of your primary assessment is to fix life threats. Simple. Alright, general impression is, what do I see? How does my patient look? What position are they in? Does anything stand out? Do I see beer bottles? Do I see pills? If there's an accident, how much damage to the vehicle? Are they out of the vehicle, in the vehicle? What does it appear to be going on? How do they look? As I approach my patient, I want to determine if they're awake or alert. Are they unconscious or not? If they're awake and alert, I'll generally try to determine person, place, time, and events pretty early on, or something within that reason. Tell me this patient knows what's going on, or deemed A&O times 4. Determine the chief complaint or apparent life threats. What does the patient tell me is bothering them today? Out of everything, if there's multiple things, what's the one thing that's bothering them most? If they're altered mental status or altered level of consciousness, that becomes a chief complaint. If they're unable to tell me what's going on, they're not A&O times 4. We dub that their chief complaint then. Alright, down to the ABCs. Is their airway open? Are they talking, speaking full word sentences or not? What's their rate of breathing? How well are they breathing, their effort? At this time, I like to get my lung sounds, throw that SpO2 monitor on them. Well, I got the stethoscope out to get the lung sounds, so might as well go ahead and get heart tones. It tells me a lot about them going on. If there is a life threat at that point in time, or any point in time, I would fix it then when I found it. Next, I'm going to check the circulation. What's their pulse rate? Qualities of weak, strong, regular? Bilaterally, are they equal? And the distal radial pulses, are they equal? Skin color, temp, and condition. Any major bleeding? If I see bleeding, I find it, fix it right then and there. Cap refill tells you a lot about your patient, overall circulation, and whatnot. Under 2 seconds, generally preferred. I'm going to check my pupils. I got the equipment there. It's an ABCs. The more you find out now, the better outcome you'll have. After this, I determine, is my patient big sick or little sick? Do I need to do a rapid trauma assessment, rapid medical, or focused trauma or focused medical assessment? Alright, so CAB, circulation, airway, breathing. When I see bleeding anywhere, upon approach, I focus on that. If they're bleeding out, it doesn't matter if I collect their airway or not, provide supplemental oxygen, all that oxygen saturated blood is going out through that hole. So we find it, we fix it. Direct pressure, if that doesn't work and it's arterial bleeding and or just heavy bleeding, don't hesitate to use a tourniquet. If direct pressure does work, try a pressure dressing or pack that wound.